I'm Nadine Fornellos-Martins, Executive Director at Harvard Medical School, where I lead Mass CPR. So I'm very pleased to be here today, and I will be introducing our keynote speaker, Dr. Monica Bharel. Dr. Bharel is a physician, internist, and public health innovator who focuses on using data and analytics to advance health and equity. She is the clinical lead for global health, public health, and public sector health at Google, where she drives collaboration and innovation through new data insights, AI tools, and research partnerships. Previously, Dr. Bharel served as Commissioner of the Massachusetts Public Health Department from 2015 to 2021, leading the state's responses to both the opioid crisis and the COVID-19 pandemic, and spearheading the creation of the Commonwealth's first integrated public health data warehouse. She has more than 20 years of experience in general internal medicine, including as Chief Medical Officer of Boston Healthcare for the Homeless. Dr. Bharel holds an MPH in Health Policy and Management from the Harvard T.H. Chan School of Public Health, an MD from Boston University School of Medicine, and completed her residency and chief residency in internal medicine at Boston City Hospital and Boston Medical Center. And now I will leave the podium to Dr. Bharel for her keynote. Thank you.
Hello, hello, good morning. Lovely to be here with all of you. Set myself up. I get excited, I keep talking, so I gotta make sure I'm on time. Can you all hear me okay? Lovely, thank you. Thank you for that introduction. It's wonderful to be here with all of you to talk about AI-powered public intelligence, a subject near and dear to my heart. I'm really grateful to be particularly at this I2B2 conference. The I2B2 tools have really been leaders in thinking about how we turn data to action. So it's great to be part of this discussion. I'd like to take you on a journey that led me to where I am in thinking about these tools from the patient bedside to global public health surveillance, and my experience in the power of actionable data and how to integrate data. Here are my disclosures. So this group knows this, but just to center and why it matters in public health, and lots of people use different definitions for public health versus medical health versus health overall. So public health, health and access to health care is part of public health. Some of the ways that are obvious that we need data is in outbreak surveillance, resource allocation, informed policy making, and equitable distribution of resources. And when you look at that data and the study of data and patterns in data, epidemiology is really the base of the work that we do. And when you look at the health as a source of data, health is a massive generator of data. EHRs are the primary clinical input to data systems, of course, and having access to that data is critical to be able to do many of these things, hence the importance of I2B2. In the US, our data systems generate 30% of the world's health data, and globally we know that only about 3% of data that's generated in health is used for analytics, right? So there's a lot of data being generated and not a lot of data becoming actionable data. So you heard a little bit about my background. I was honored to be at Boston Healthcare for the Homeless for over a decade, over 2 decades if you count my time in training. And during that time, my patients were my best teachers about how we think about data and what we should do with it and how it could actually impact their lives. In my last year at Healthcare for the Homeless, I started asking my patients this question: what will it take to make you healthy? It was my, N of whatever, 100 patients to try and understand what my patients were experiencing and how we could assist them in the revolving door of coming in and out of our clinics, emergency rooms, and inpatient facilities, and quite frankly, not seeing much improvement in their medical outcomes. And so I asked my patients these questions, this question about what will make you healthy. And some of the patients said, oh, the diabetes medications you're giving me, or the referral to the cardiologist, but I think most of them were just being polite when they said that. What the vast majority of them talked to was something outside of the clinical room: connection to my family, right? Re-engagement in my community, having purposeful work, having a place to stay, having a place to store my medication safely. So, at this juncture, my patients were really teaching me about what matters beyond their medical care is the outcomes for them and their full experience of health. And it really pinpointed for me, if that's what our patients are caring about, if you think about that and you go back to the data structure, our data structure is not set up for me to be able to understand how to help them get to those outcomes, so those silos of data that you heard the dean talk about. The other thing that this siloed system does for us is that it's very inefficient, and again, in the end, doesn't get the outcomes that we need. For example, I asked a patient of mine, your diabetes and hypertension and all these things that you're trying to manage will get better if we could find stable housing for you. Are you working with a case manager on stable housing? And the patient said to me, well, which case manager does that? I have 6 of them, right? One from multiple different organizations, and none of them have actually talked to me about housing, right? So in a way, our systems are so designed to put resources in, but yet not connected in a way that it can be of benefit to the patient. So when I was at Healthcare for the Homeless, I'm going to talk to you a lot about data beyond medical data and how to make that connectivity happen. But even within our systems of medical care, there are silos of data. So at the time, our Healthcare for the Homeless data, Boston Healthcare for the Homeless data, was not connected to hospital data or social service data. And we wanted to try and when I was at the Chan School, the project that I did was trying to connect data from our Healthcare for the Homeless to medical care. You might say that's simple, but even now, I'm talking many years ago, I don't want to give it away how long ago, but even now, within our medical systems, we don't have great ways to understand if someone is experiencing homelessness, right? And that, as my patients taught me, as I'm giving you these examples, is such an important indicator for improved medical outcomes. So what we did was we took over 6,000 of our patients and connected them to Medicaid data, obviously in an aggregate, secure, anonymous way, and were able to gain insights that really revolutionized the way we took care of our patients. To give you an example of one, we looked at patients who were being admitted repeatedly for medical interventions, and we found that the majority of those had behavioral health issues, and many of those behavioral health issues were untreated. And that allowed us at our program level to switch the dynamic and say, we have dozens of internal medicine physicians and not enough behavioral health clinicians and psychiatrists. So it helped us make arguments to do that kind of care. So a small example I gave you of how coming across those data silos, we were able to change the way in which we cared for our patients. If anyone's interested in more details and other things that we found, this is the article that we published in the American Journal of Public Health. So what were my patients? Any of you who see patients here will understand what I mean when I say patients that are our best teachers, right? Because it's the residents, the patients, the individuals that we're trying to impact can give us the most information. So that's that narrative of what they're experiencing and how we can help. And then it's our job and our tool to then say, how do we then look at our data structure and systems, right? Because that knowledge, as I said in the slide about public health, is what will drive us understanding how to allocate resources, how to care for people better. You may hear me saying this and say, well, this all seems obvious. But if it seemed obvious when I said it 20 years ago, it's also obvious now, and yet our systems aren't doing that. So that's why I keep repeating it. What my patients were teaching me, and what many of you have hopefully seen, is really reflected in the CDC Health Impact pyramid. And when we look at impact and how we can have impact, and how I hope many of the researchers and academics in the room can have impact, is it is very important, of course, to have clinical interventions, counseling, and education. You'll see on the right-hand side some examples of those that we often use in healthcare settings. And then as you go down the pyramid, you can see the spaces where we can have the largest impact. So as we think about I2B2 data, thinking about the public health impact in these areas, like changing the context, like, for example, some work we did at the Department of Public Health to make tobacco less accessible to young people, right? So changing the laws, changing the access, to addressing issues around poverty. I gave you examples of some of my patients at Healthcare for the Homeless, and education, et cetera. As we go down that pyramid, we enhance our impact to our patients, to the residents, to populations. And again, the way through this, if you think about each one of these layers, and then again, go back to how the data is structured, we can see that this is part of the reason why we have this continued problem, because of the way the data is structured. And I2B2, some of these public health surveillance tools are really trying to get at that, and how do we really look towards the integrations in a way that will impact people. And as some of you who may not be people or patient facing, I hope that you can think about, as you do your work, how do we think about ways in which who is impacted by this? And are we bringing this data together to have an interesting paper, and will it also have an impact on someone along this sphere? When I went to the Department of Public Health in 2015, my colleagues and I developed this DPH house, as we called it. It sat in our lobby for almost 7 years. And what we did here is try to inject very intentionally precision public health, which is what any good public health intervention is, right? Trying to use integrated data to improve health outcomes. And what I'll tell you about this house is the vision, the mission, the foundation of the people, and the way we do the work was unchanged. What we injected was the information in the middle. We called it our 3Ds. So using the data that we have to understand and highlight the determinants of health in order to find disparities within our system, right? So where's the data have disparate outcomes for some versus others, and then use our limited resources to target those interventions. When I was at the Department of Public Health, we were resource constrained. There's even more resource and individual constraint within our public health and health infrastructure within this country, but also globally. And so being able to understand where you take limited resources and get them to where the need is the highest, and then measure those outcomes to see if things work is really critical right now. So really timely in terms of the placing of this conference. And the first use case that we did related to this concept, the first use case was around bringing data together to address the overdose epidemic. So at the time in 2015, the governor's #1 priority was to bring down the rapidly rising overdose death rate. And given my clinical background, I said, let's take a step back. For many decades, the health system, the medical system, has been addressing substance use disorder, but it clearly isn't working, right? How can we take this model and think about where all the data sits and understand better so that we do something different this time with our limited resources to address this emergency? And that became our first use case and argument for a concept that my colleagues at the Department of Health were thinking about for many years already. And that is, you heard mentioned in the introduction, the Public Health Data Warehouse. Now, those of you who are very technical, I'm pre-warning you that this was 2015, 2016. It was rudimentary, and there were literally, 4 or 5 of us at the Department of Health working on this. We, by the way, were able to get approval because we had to do a legislative change at the time, which wouldn't apply now. So we had to change the law and get approval to do this. And the most important thing that we agreed to was to do it with no change in budget. So what we did is we used the APCD spine to have project ID numbers, and then we took information from all of these, these buckets. I know it's an overused term, but silos is really, it is what it is. So just to orient you to what's happening here, thankfully we had a robust APCD and CHIA partner to be able to use that as our spine. And then we brought data together, much like I2B2 does now in a much more sophisticated way. We brought data together temporarily to answer questions in a de-aggregate anonymized ways. And even if you look at this, you'll see here that the orange buckets, which are public health data, if you look at that, even within the Department of Public Health, where I was the commissioner, we couldn't bring different data pieces together to try and take data to action. So within public health, public safety, criminal justice, you can see that we had the medical data through Mass Health and medical claims and hospital data, which was really at the Department of Public Health the first time we, in a very integrated way, were bringing together medical data with public health data, right? And it's still, I would say, one of our largest challenges overall as health systems is bringing those two pieces of data together. The dean touched on this. There's reasons for it that are beyond technology, and that includes, we hold this information, PHI information, sacred for our patients, right? So it's really important that we understand how is it coming together, what is the governance, is there trust, is there secure systems? So we spent a lot of time, most of the time was in setting up that governance for this structure, and then bringing the data together actually was an easier part of that. And I raise that because even today, we have those same issues, and the systems are much more capable of doing those things in a secure and safe way. So part of it is our education of how the systems have improved to be able to do that kind of work in a safe and secure way. But that must be there. Just to give you one example, because I could spend all my time talking about this topic, it revolutionized the way that I, in the department, thought about our care and that resource allocation and disease surveillance, and the way that we did our work, and the way that we did our work on a foundation of health equity, finding disparities and using our resources in those areas. So just one example to give you, this was the first time, you'll see the criminal justice buckets here, this was the first time that we brought together public health and health data with criminal justice data from jails and prisons. And one of the things that we found out, one of our main findings in the first year, was that individuals who had an interaction with criminal justice were 120 times more likely to have an overdose. We also were able to find out that that risk of overdose was highest in the weeks right after they were released. So that then over the next few years helped us work with the prison system and each sheriff, because sheriffs are run by jails are run at the county level by sheriffs, to incorporate medication for opioid use disorder, to incorporate plans for warm handoffs when people are released into our health system. So it really changed the way that we were able to care for individuals in a way that then got at one of these highest risk groups. That's just one example. There's many more. If anyone's interested, we wrote this up in the NEJM Catalyst. Since then, the Public Health Data Warehouse still exists. Since then, we've done maternal and child health has been a topic, as well as COVID and coronavirus, and looking back at some of that work. Speaking of coronavirus, I was at the Department of Public Health for, as was mentioned, almost 7 years, including the first 2 years of the pandemic. It was a very, very challenging time, and a time where we were having to execute rapidly in an area that was scientifically a gray zone and changed rapidly, which involved having to communicate, having to make decisions, having to do things before we had all the information. So during that time, by the way, during that time is when mass CPR was born, right, in March of 2020. During that time, there were many lessons learned. Sometimes if I think back of it, I wonder how many we retained, but we all will continue to bring forward the lessons that we learned from that time. And there's a couple of things. So on the positive side, I keep talking about healthcare systems, public health, and having our own silos. We really came together in a way that I had never seen before. The health system competition, the trust, the ability to bring information together was extremely powerful in the way we collaborated on simple things such as making sure each hospital had enough ventilators, right, and sharing between systems, to more advanced things like being able to track the cases, the hospitalizations, and the deaths from coronavirus. If someone were to look, let's say if they had like an Artemis view of our planet, they would say, why was it so difficult to understand cases, hospitalizations, and deaths from coronavirus, right? Which really drove even some of our models about what would happen next. And that goes to show how challenging it is to bring these data systems together. In some ways, we've advanced from that, and in some days, I hope the next pandemic doesn't come soon. It really did highlight where the data integration gaps are and the ways in which we could move forward to that. And there have been advances since then. During the COVID pandemic, we were able to use this integrated data system that we had developed, right? So we had been able to develop that. So then when a crisis came, we had the tools and the building blocks in place. It's much like thinking about I2B2, mass CPR. If you have the building blocks in place, when a crisis happens, you already have the tools to be able to address that. And we were able to use those tools to really highlight how to distribute vaccines, if you remember how limited they were when they first came out. And we were then able to look at areas where there were higher risk individuals, there had been higher deaths, there was less access to PPE, there was less capacity to do this 6 feet apart, and really target our vaccinations to those areas. I spoke about people in the criminal justice system in wave 1, including some of the highest risk groups that folks talk about, like individuals who are elderly or in nursing home facilities. We also were able to include individuals who are experiencing homelessness and individuals in the incarceration system. And that came because we had these data tools to be able to highlight that. We then took a data-driven approach to community engagement and action, and really were able to do bespoke community messaging, right, at the hyper-local level to engage individuals around vaccination and treatment and care, and then also get vaccinations to those areas in ways that were unique, such as mobile vaccination. And I raise these for you because that tool, when we set it up, was set up for one reason. Multiple crises happened that we were able to address with that. And then when the pandemic, the first pandemic in 100 years came, we were able to use those tools, right? Because it's like developing muscle memory. But the point of bringing these things together is that you can then use them for multiple things that you would not be able to envision before. So now, maybe some of you saw where I'm speaking from. I was like, when is this woman going to get to 2026? I give you that background so that I can introduce you to some of the exciting tools that are available now in this current age of AI. And in this current era, there is a real opportunity for us to think about public health surveillance. I've given you those building blocks of ways we've thought about these things before, and there's a real structured way in which we can engage in these tools, but it'll take intentional engagement because it won't happen naturally without us being engaged. So there's 2 areas that I think about. There's lots of different ways that AI can be used in public health and health surveillance. There's 2 areas that I think about. One is the data harmonization area, a lot of what I was talking about. And the other is in optimizing use of AI and generative AI to do the work that we already need to do, right? And then to take that and advance our analytic capacity. So first, around data integration, if you think about this, this is really what I was talking about with the public health data warehouse, right? So you take the health services data, right, which is the healthcare system data, which we're here to talk about today, and you take that and you integrate it with all these other factors that, as I talked about my patients and what matters to them, is important. And in today's cloud-based advanced analytics systems, making this data harmonized is more realizable than it ever was before. So if you think about what I explained to you, what we did with the public health data warehouse, that is like using a compass, and this is like the invention of GPS, right? It's like it's a whole new world, and things can be done more securely, more safely, and more rapidly. So it's really important for us to think about the tools that way. Several of us, we had to ask from the public health system in the US, can you help us think about how to use AI and generative AI in our work? So we came up with a framework that from left to right is from easiest to more challenging within the public health system. So it's using these tools for communication, for operational effectiveness, and then data analytics, which is where the real exciting like moonshot work is happening. So just to walk you through a little bit, so as you think about your work and what the public health system needs, you might be able to see where there's a overlay here. Oh, sorry, and we did publish this in Health Affairs if you'd like to look at that and see some of those details. And then as I talk to you about those 3 areas, I want to let you know that from sitting on a health team within a large technology company, it's interesting because the way we think about health also is the way that it's embedded in health system thinking within large technology companies. So the language is a little bit different, but the concepts are the same. So it's about meeting people where they are, how are they engaged with technology, how are residents engaged, patients, how do they show up, right, to exam rooms, and then what are the organizations such as healthcare systems that are using the data, and then how do we think about in the greater health ecosystem, which is by definition public health, and then how do you use these advanced capacities to really engage in all of those. So talking about communication, these are the forms of communication important in public health. I mentioned a little bit about communication, external to general community, external to specific partners, and then the internal fire hose. Interestingly, in a research center or a healthcare system, many of these still apply. The reason I bring this up is because in this age of how we communicate with the general public and how the general public gets information and how we build trust and engagement, these communication things are really critical. And much of our time when I was at the department was spent producing documents, right, and other things in that middle bucket and the last bucket. And there's ways to enhance the work with tools, right, especially with generative AI, that can be really powerful. And if you have the right medical knowledge feeding into that, then this really becomes a flow of high quality information where it's most needed. So getting back to this and talking for a minute about operational effectiveness, I want to give you a couple of examples. So here are some examples in healthcare about how these tools are being used. So HCA Healthcare has created an AI nurse handoff tool, if you will, and what they measure in terms of improved efficiency is they saved 10 million hours from the streamlined patient handoff, right? So it's always, obviously, the nurse is still in the loop. There's always a human in the loop when it's health and healthcare, but they were able to improve the efficiency of use of that process, decrease errors, right? That kind of stuff they're still measuring, but the time efficiency is here. Here's an international example. UB Health in Japan used an AI-powered discharge summary generator with, again, a human in the loop reviewing it, but some of the basics are first put together so that there's a decrease in over 40% of admin workload for nurses. And in the end, these healthcare examples, the goal, right, is to have that nurse, that clinician, have more time at the bedside with the patient in the human-to-human interaction. Let's go now to an example in public health. This is the state of Illinois. The governor heard about the rising rates of behavioral health issues and unmet need of children in the state. And based on that, we were able to help them design a data portal where the 5 agencies, remember I talked about my patient with the 6 case managers, the 5 agencies that all engaged with children at some point with behavioral health issues, but nobody had ownership over that child's care, were able to integrate in the background and develop a resident patient portal so that when the patient or the patient's family engaged, it was a seamless process to them and easier to navigate the system to get the resources that existed, but they weren't getting to the children who needed them most. So I want to end by talking about this really exciting bucket on data analytics, which I hope you'll see some ways in which your work can fall into this. And we talked in the beginning about the analytics of public health. This is a space many of you work in. So I just want to go through a couple of examples and end on one about geospatial reasoning that I think you'll appreciate. So first, some of you may have heard of this. There are multiple tools like this. I'm telling you about the ones that I know. So Co-Scientist is an AI-powered tool that's built to assist in biomedical research. And what it does is it takes large volumes of scientific data and other information, right? And it's a closed system, so you're feeding in what comes into the system. It's not pulling from the web. So it's a closed system where you take bespoke, chosen large amounts of scientific data, and in natural language explain what you're trying to do. And then it is able to generate ranked hypotheses and research plans based on this natural language input. And researchers who have tried this, including at places such as Stanford and the Imperial College in London, have said it's decreased the burden of the initial work to be able to actually get to the research manyfold. And it's, there's a lot of potential for this. Another tool I wanted to explain, share with you that some of you may know about is called MedGemmer. It's an open source tool, and it's a tool that's fine-tuned with medical data. So it's a large language model, but it's fine-tuned with medical data. So it allows developers to build state-of-the-art tools for many things, including one of the MedSig one is really about image understanding. And when that was one of the first areas where these advancements were really seen in health, because images are really a good place to start with that kind of work. Talking about images and enhanced ability for diagnosis and improved patient care with medical images is really one of the first areas in medical care that we saw this work, and there's lots of advancements in this space. Another example that I want to share with you is the Health Acoustic Representations Tool, or HEAR tool. And this is a bioacoustics foundation model that can be used to analyze sounds and ID subtle changes that can indicate early disease. So for example, there's a research study going on right now of characteristics of cough to identify tuberculosis. And this may sound far-fetched, and you say, I have other tools to identify tuberculosis, but that's here in Boston, Massachusetts, right? In many parts of the world, there are not clinicians to find these early subtle signs of tuberculosis, so this becomes an early signal in order to draw people in, then of course to the standard of care of medical treatment, but how to find individuals early enough that treatment can assist them is some of the things this tool is being looked at for. This is another consortium project that I was involved in. In partnership with this On-Time consortium, we developed a tool that uses the same AI-driven traffic predictions that are used in the MAPS app to estimate average travel time to nearest emergency OB facilities. And the goal here was to help, for example, in Nigeria, was to help decision makers ID and respond to areas where geographic access to these facilities is limited. And one of the interesting things that we found, right, because in many parts of the world in large cities, driving a mile can take over an hour. So even though it looks like on a map that a facility is close, right, is that contributing to some of the high maternal morbidity and mortality rates, infant mortality rates, and can something be done about that? And, an example is a minister of health saying, I was looking at this area, right, it's like a heat map, green is good coverage, and red is poor coverage. One of the administrators saying, when I looked at this, I realized, because again, you're a human in the loop who understands the system well, and they're saying, I think if I pave this road, instead of having to build an expensive another site, we would actually see improvement, right? So it's again, looking at what are the resources we have, how can we best use them to find improved health outcomes. So the final tool I want to talk to you is about Earth models, and I'll go into a little bit of detail in one specific one that we've used in public health settings to close out. So the big questions for us in health are, we're interested in understanding how geospatial data can be used to predict outbreaks, enhance detection, and inform modeling of transmission dynamics. And so this is one of the tools within the Earth AI suite of tools, and this is just an overview of how we built it. So the first step is to build a foundation model. This was done combining aggregate data from places that usually don't come together, like search trends, maps, busyness, weather, air quality signals, into a self-supervised graphal neural network across the globe. This results in a unique set of features that describe administrative regions like postal codes around the globe or zip codes. And then you can take these features and combine them with open access ground truth data like disease prevalence or socioeconomic statistics to power downstream geospatial risks and geospatial tasks. So any task where information about the population at a location may be helpful is a useful use of this tool. And by the way, that is the definition of public health, right? Understanding where people are in their space and how that impacts their health. So looking at this, what we really get at is the way that this PDFM, I think of it as like a location fingerprint that captures a region's population characteristics, their complex interplay with the environment, and it captures contextual information about how communities and people live and how they interact with their communities, right? And this is the stuff that's really hard for us to do. And if you go back to the patients I was talking about, the most impactful in their health outcomes. So who the people are at an anonymized level, of course, what's in their environment, what are the people doing, what's the information that they need. And this context can build, develops the power for downstream geospatial tasks, right? And especially in public health. So it's an ability to take the geostatistical approach we have now and envision it as a geospatial approach to add to the information we have already. So in this geostatistical to geospatial, here are some of the things that we can do. Excuse me, sorry. We can do interpolation about, where there are small gaps in missing information, extrapolation, where large areas of the country, for example, are missing an understanding of what's happening there, super resolution, and nowcasting and forecasting. So I'll close by giving you a few real-time examples. So identifying measles, I took a case connected to HMS and colleagues that we work with at Children's, including Dr. Brownstein. And looking at measles, their group's interest was to look at measles as it resurges in the United States. And if you look at a general map like this, and we do a lot of hotspotting maps, right? And you might see areas like this, but you're not really, areas that you think might be lower risk, we're not really getting to the neighborhood level, right, to be able to understand what's actually happening. So for a local example, if you think about a place like Boston, right, and if you just look at a heat map, you may miss some neighborhood differences that are important in providing care in, say, Back Bay versus Roxbury. So there's a good concept of getting at that. And so what we were able to do is looking at these neighborhood levels, you can see under-vaccinated pockets that aren't visible otherwise, and this hot spotting helps with resource allocation, right, and to be able to go into those neighborhoods of high risk and do the education there. And that one of the things that is really important in this kind of thing is from being in public health and a public health practitioner, these decisions are being made already every day. So already somebody is deciding in Boston, where should I go and do the education today, the outreach, right? Where should the mobile van go? And that information is based on whatever information we have, sometimes local sources of information, but if you can power that with this kind of evidence to allow those who are doing the work at the front line, the community health workers, the outreach workers, the physicians, then it can become much more powerful. Here's another example from our colleagues at Cooper Smith who use these foundation models to help with HIV, STD, and TB protection. And really what they were trying to understand is in Malawi, where to place healthcare services and where they would be more useful. Again, low resource area, trying to understand where the resources that you put in would be most impactful. Finally, I'll give you an example from the Democratic Republic of Congo, where they were interested in enhancing their existing cholera model. And so we worked with them to use, remember the Earth AI is a constellation of different tools, and two of the tools that we used, WeatherNext and Times FM, were able to decrease their error rate in their standard geostatistical tools, so improve their capacity to understand that. And by the way, this happened to be DRC, which is now, as we all know, undergoing this devastating outbreak of Ebola, and these kinds of tools, again, using the building blocks, and then able to help them in that work as well. So I'll leave you with this thought. Somebody shared this with me, which I found very interesting. So how long it took to get to 50 million users. So airplane, 68 years, internet, 7 years, and Gen AI, 5 weeks. So we're at this incredible pace, right, of adoption, accessibility, usefulness of these technologies. But I'll say from my inside view, for us to use this to improve health outcomes, to address inequities, to really bring together medical and public health knowledge. That won't happen naturally. It'll take those of us in this room to really grasp these agents, use them, trust them, right? Learn how to trust them, learn how to put the appropriate guardrails on so that we can use them to improve outcomes for everyone. Thanks so much for your time. Really appreciate it. the time? Yeah.
Is it working? Yes. All right. Thank you. Thank you so much, Monica, for this great presentation and for showing that public health is a lot more than health, and how you're bringing all the tools together without necessarily always reinventing the wheel. There's a lot of value to that. So we have a few minutes for questions, and we can start with taking questions from the audience, the in-person audience first, and then perhaps if we have time, we can then switch over to the virtual audience. So there are microphones left and right. Oh, I see someone on the left already. All right, go ahead.
Thank you for that amazing talk. I just want to take you back to the pyramid and thinking about the interaction of the different layers, and where there's someone in a microenvironment, let's say socioeconomically, or prison, where there's a block between seeing the person and seeing what's going on with them, and this phrase from Atul Butte of scalable privilege, that they're just not being seen to understand what is going on. So it's that exposing that so that the individual could be seen because of the obfuscation of the lower layers. How do you think about that, and give them a shot on goal to really get the treatment they need?
Sorry, finish your thought.
No, that's it.
You said it in a very poetic way. I should have written it down because I'll use it next time. So that is, the foundation of the points that I was making is around how could, there's the narrative, there's the people, right? And you have to bring that together with the data. So in my experience of changing health policy, at an institutional level or at a state or larger level, is around we have to have the data points that can lead to action, right? So if we want to be able to have that person in the prison cell be visible, right? So there's the narrative, there's the advocacy, and then from a policy point of view, what are the data points, right, that can help us with that? Because one thing that I can stress is that, in the world of policy and action, these decisions, things are being done every day, and this is about steering them to the place that we then can see, as you said, in that prison cell to say this is the person who can most benefit from it.
Thank you.
Maybe I think this person was first. Okay, go ahead.
Thank you for your fantastic talk. So for public health data integration and AI utilization, can you talk about something related to the Internet of Things and smart hardwares to collect data and integrate this data into public health database and using AI tools for data mining and data accession?
Yes, thank you. I think you're asking about general, like the collection of the data and from the internet and public sources. I think that's what you're asking about. Yeah, thank you for your question. To your point, there are AI tools that can actually do that kind of scraping of the internet, if you will, that are very powerful now. Again, that data comes together and then they need to be evaluated. But for example, many countries are doing internet and news source scraping to be able to understand where things like early disease indicators might be. Like, for example, the hantavirus, is there something happening on social media that is pointing to a strange illness that can help them do that? So there's a lot of tools available for that, and people are starting to use them. I think that's an area of research that would be very helpful too, to be able to have ground truth data. You can go back and look at things where there's relatively large amounts of data, like the coronavirus pandemic, and say, can we go backwards and validate those tools to see how useful they are? So it's an area of research that I'd like to see more work in as well.
Thank you.
Moving to the right side.
Hi, excellent talk. I agree there is a lot of progress going on with respect to AI and everything in public health. But when I compare the small town, like local board of health, not the state board of the health, I see a lot of barriers actually with respect to data analysis or AI uses, what we could do to overcome those limitations.
Yeah, I totally agree with you. And I gave my examples because I was at state government, but I work a lot with local boards of health. And, part of the reason we put out that article that I showed you is so that people have a sense of where to begin. So, for example, if you remember the 3 buckets, the communication, the operation, data analytics, the last few things that I showed are advanced data analytics. Of course, some of them can actually and do. But many local boards of health won't be able to do that. So one of the things that I'm seeing, we'll have a piece coming out about this shortly. One of the things that I'm seeing is that the gaps continue to widen. So the existing disparities in use of technology will widen if there's not an intentionality about learning them. So the mistrust, which trust should only be there after being educated and learning that the appropriate guardrails are in place. But that gap is widening because of the lack of use of the tools. So some of the examples that I gave you, for example, in that first bucket of communication, I encourage local health institutions to start using those because there are free online resources where you can, one of them is Notebook LM that I use all the time, where you can input your data. So you can put in a brief and a scientific report and an article, and then ask it to create a brief for the council meeting. And so then they start to use the tools in areas that they know and start to get comfortable to see what the art of the possible is. Because what I'm finding is that the AI fluency gap is widening. And so I think part of the work is to get people to use some of the tools and see where there's potential and where there isn't.
Okay, thank you.
Thank you.
Do we still have a minute for Griffin's question? All right, go ahead.
Thanks for the great talk and again for coming to our symposium today. One of the questions that keeps coming up with our mass CPR data network is the recency of the data and time lags and what that allows and not allows. When you're at a global Google scale and there's many different data sets, some are truly real time, others have years time lag, differences between different countries. How do you manage all those differences in time scales?
Yep. So thank you for having me here today, Griffin. It's great conference. So part of that is around thinking about the geostatistical tools versus the geospatial tools that I was speaking about. And as you know, in our core primary public health data, sometimes we have access to real-time data. Most of the time, data lags. And when I went to the Department of Health, I was frustrated with how long it took for our cancer reports to come out. I think they lagged by multiple years. And there's some system things we could do to improve that. But some of that is that the messiness of the data calls for really rigorous, right, analysis and cleaning of that data to be able to use it. So some of that, by the way, we can improve the lag of data. I'll get you your specific question, but some of that we can improve the lag of data using some of these tools to help us do that. So that's one thing. And the second is that all of this data, some of the moving from the geostatistical to the geospatial, the tools can be really helpful in the nowcasting, forecasting piece. And you could say, depending on the depth of the data you need, both spatially and temporally, you can adjust that to say, here's the primary data at this level, and here's the predictive data, and then with eyes wide open, understand where you're bringing those together to get to some of those resolutions that you need.
Thank you.
Thank you.
Thank you all very much.